Shock, a comprehensive approach based on advanced trauma life support guidelines. Welcome to the Everything Surgery podcast, where today we delve into the critical topic of shock, guided by the principles of the Advanced Trauma Life Support Guidelines. This approach is foundational for trauma care, emphasizing a systematic and prioritized method aimed at the rapid recognition and management of inadequate tissue perfusion, a condition that, if left unchecked, leads to irreversible cellular damage and ultimately death. Core philosophy and definition. According to Advanced Trauma Life Support, shock is defined as a state where there is insufficient blood flow to the organs and tissues, resulting in inadequate oxygen delivery. The most essential principle to understand is that shock is a clinical diagnosis. One should not wait for laboratory confirmation or a drop in blood pressure to make this diagnosis. Notably, low blood pressure is a late and dangerous indicator of shock that has progressed beyond compensation. The primary objective is to recognize shock early, determine its cause, and initiate treatment to restore adequate blood flow and oxygen delivery before any irreversible injury occurs. The initial assessment and shock management of shock is fully integrated into the primary survey of trauma assessment, as shock is fundamentally a problem of circulation. The process begins with ensuring a clear airway and effective breathing to maximize oxygen delivery. The next critical step is circulation with a focus on controlling hemorrhage. Clinicians must carefully assess skin color, looking for pallor or mottling, and check for cool, clammy skin and delayed capillary refill. The pulse should be evaluated for rate and quality, noting whether it is weak or thready. Additionally, listen for changes in level of consciousness, such as agitation, confusion, or reduced responsiveness, which can indicate cerebral hypoperfusion. It is important to remember that so-called normal blood pressure can be misleading. A trauma patient may lose up to 30% of blood volume while maintaining an apparently normal blood pressure due to compensatory physiological mechanisms like increased heart rate and blood vessel constriction. This stage is referred to as compensated shock. The onset of low blood pressure signals the failure of these mechanisms. A shift to uncompensated shock. Classification of hemorrhagic shock. The Advanced Trauma Life Support System classifies hemorrhagic shock into 4 clinical categories, based on the estimated volume of blood lost. Each class is associated with specific clinical features, including changes in pulse rate, blood pressure, respiratory rate, mental status, and the need for fluid or blood replacement. For example, a patient who is anxious and has an elevated heart rate but maintains normal blood pressure is already in shock and requires immediate intervention. Recognizing these subtle signs is vital for timely and effective management. Identification of shock type. A critical component of the Advanced Trauma Life Support System is the rapid identification of the underlying cause of shock. Causes are categorized using a helpful mnemonic, focusing first on the most common causes in trauma. The most frequent cause is hemorrhagic shock, resulting from blood loss either externally or internally. Clinicians must always ask, "Where is the blood?" and systematically examine the chest, abdomen, pelvis, femur, and external sites. Other causes include tension pneumothorax, in which increased pressure within the chest impairs blood return to the heart, an obstructive form of shock. This condition presents with breathing difficulty, low blood pressure, absent breath sounds on one side of the chest, deviation of the windpipe, and visible neck vein distension. Immediate needle decompression is required. Cardiac tamponade is another form of obstructive shock, caused by fluid accumulating around the heart and preventing it from filling properly. Hallmark signs include low blood pressure, neck vein distension, and muffled heart sounds, collectively known as Beck's triad. This condition requires urgent removal of the fluid around the heart and definitive surgical intervention. Neurogenic shock results from the loss of sympathetic tone after a spinal cord injury above the 6th thoracic vertebra. This leads to widespread blood vessel dilation and relative low blood volume. Unlike hemorrhagic shock, neurogenic shock presents with low blood pressure and a slow heart rate, along with warm, dry skin and paralysis. It is crucial to always presume that low blood pressure in trauma is due to hemorrhage until proven otherwise. Neurogenic shock should be a diagnosis of exclusion. Less common causes to consider include inadequate oxygenation of the blood due to airway or breathing problems, and severe hypothermia, which depresses heart function and disrupts blood clotting. Management of these forms of shock involves securing the airway, providing supplemental oxygen, warming the patient, and treating the underlying issue. Management algorithm for shock. Management of shock in the trauma setting is aggressive and simultaneous. The The first step is to ensure the airway is secure and the patient is receiving high-flow oxygen. Early placement of a breathing tube may be necessary to reduce the work of breathing and protect the airway. 2 large intravenous lines, typically of the largest practical size, should be placed in the peripheral veins. For adults, an initial bolus of 1 to 2 liters of warmed isotonic fluid such as lactated Ringer's solution or normal saline is recommended. For children, the bolus is 20 milliliters per kilogram. The patient's response to this fluid bolus guides the next steps. A rapid responder is one whose vital signs normalize and remain stable, often indicating minimal ongoing bleeding. A transient responder shows initial improvement but deteriorates again, reflecting ongoing bleeding and requiring immediate blood transfusion and preparation for surgical intervention. A non-responder fails to improve or worsens, signifying major ongoing hemorrhage and the need for emergency surgery and transfusion. Controlling bleeding and identifying the source is essential. External bleeding should be managed with direct pressure and, when necessary, tourniquets. Internal bleeding is investigated using focused assessment with ultrasound, chest imaging, and pelvic radiographs. Patients who are unstable with evidence of internal bleeding are taken directly to the operating room or interventional radiology as appropriate. Modern concepts in shock resuscitation. A key modern concept is permissive hypotension, also known as hypotensive resuscitation. In patients with ongoing uncontrolled bleeding, aggressively restoring blood pressure to normal levels can disrupt blood clots and worsen bleeding. The goal is to maintain a palpable pulse or a systolic blood pressure of 80 to 90 millimeters of mercury until surgical control of bleeding is achieved. However, this does not apply to patients with traumatic brain injury, who require normal blood pressure to preserve brain perfusion. Damage control resuscitation is the overarching strategy for patients who do not respond to initial fluid therapy. This approach has 3 pillars: early transfusion of blood products in balanced ratios to correct clotting disorders, permissive hypotension, and abbreviated surgery focused on controlling bleeding and contamination, followed by intensive care and planned reoperation. Throughout resuscitation, it is vital to avoid the lethal triad of acidosis, coagulopathy, and hypothermia. This is achieved by using warmed fluids and blood, rapid control of bleeding, and balanced blood transfusion strategies. Summary: in summary, the advanced trauma life support approach to shock involves early recognition based on clinical signs, not just blood pressure. Treatment is aggressive and begins during the primary survey. It is essential to identify the type of shock using a systematic approach, always remembering that hemorrhage is the most frequent and life-threatening cause. The patient's response to fluid administration guides further management, and for those most severely injured, the principles of damage control resuscitation are applied to stop bleeding, transfuse blood products, and avoid the lethal triad. Thank you for joining us on the Everything Surgery podcast. If you found this discussion valuable, please like, share, and subscribe for more in-depth explorations of essential surgical topics.